I'm Dr. Mark Gold, and this is the Gold Standard. I'm so happy today to have Dr. David Smith join us for the discussion, let's say, of the history of addiction medicine and the evolution of the drug crisis in the United States. Because Dr. Smith, David, we call him, or Dr. Dave, was there ground zero the first day. When I think of addiction medicine and pioneers in addiction medicine, I always think of Dr. Dave.
Thank you.
Why? I mean, I'd say, Dave, if you could start, let's go back to 1967. I was just in high school, and you were starting the Haight Ashbury Free Clinic. That's about the date I remember, that my high school, we joked about that one time when I visited you. You started, and I was still in high school. How could that be?
Well, thank you, Mark. And again, I really appreciate your leadership in addiction medicine. I will give you kind of a brief historical narrative. I lived in the Haight Ashbury when I was medical school and my training, and the drug culture started to evolve there. It was the summer of love, Grateful Dead, rock and roll, drug, sex, rock and roll. And I was running the alcohol and drug abuse screening unit at San Francisco General Hospital. I was the local drug expert. And I saw all these young people flocking in to the Haight. And of course, at that time, addiction was a crime, and doctors that treated addiction were potentially guilty of aiding and abetting a felony. So I went to the city and wrote out this beautiful narrative on the addiction problem and how a freestanding clinic could be a benefit, and dealing with this special population. And it was the war on poverty. They had set up a clinic in Watts, and I remember going down there and seeing this clinic, and I thought the government would be really supportive of it. And they responded by saying, absolutely not, the health department, absolutely not. We want them to go away. If you set up a clinic to help them, they'll stay. We don't want them to stay. And that triggered a memory of mine, Mark, as I've just recently written in my book, Healthcare is a Right, Not a Privilege. My grandparents migrated from Oklahoma to the Dust Bowl, and we were labeled as Okies, and they said, Okies go home. And so I've always been kind of for the underdog because I've seen this discrimination. So in spite of all this, I found a zoned medical facility in the Haight Ashbury that had recently been vacated, and was David E. Smith, MD, and Associates, doing business as the Haight Ashbury Free Clinic. And we basically, during the summer of love, there's thousands of these young people flocking to the Haight. And what happened was that it was zoned off. If you got outside the Haight Ashbury, you were arrested. If you stayed in there, said if you're crazy enough to work there, you can do that. And we saw about 250 patients a day. Our funding source was the Grateful Dead, whose house was just a few blocks from ours. Janis Joplin, Jefferson Airplane, because that was the center of the counterculture revolution. And we evolved in an integrated program of medical, psychiatric, and addiction medicine, in part because it was so difficult to get these young people into the local hospitals. But it's a lot of LSD bad trips then, as you know, Mark, you've written about it. So we did a lot of work in talking down bad LSD trips. We had a little aftercare program. We ended up with 3 buildings on near 558 on Clayton Street. 409 Clayton Street was a psych facility. 529 was a detox facility. So there was 3 programs within a block and a half area. It's actually on the San Francisco history tour now. They do history tours of that area. So we had this localized integrated program uh, taking care of this population, and then suddenly things started to shift. You've written about it, Mark. We started seeing the introduction of methamphetamine. Started seeing methamphetamine psychosis. Then we started seeing violence. And this area of the Haight Ashbury is just a short distance from UC Med Center. And a lot of the early volunteers at the clinic were staff at UCSF and med students. For example, it was such a different era than now. It's hard to imagine, but we had a fully stocked pharmacy for a 24-hour-a-day clinic. The actual structure of the clinic was built by pharmacy faculty from UCSF. The detail man came in and just gave us these large quantity of different medications. And the cost of a fully stocked pharmacy operating 24 hours a day was the cost of the boards. It was about $25 because we had all this stocked up. So it's such a different era than now. And in that particular aspect, that's when I started getting involved in trying to integrate addiction medicine, as we knew it then, into the mainstream. And I coined the term addiction medicine because I wanted to get it viewed as a medical illness. At the time, it was considered a crime. I felt that if we developed a medical specialty and gave it a name that the mainstream of medicine would accept, then we could make progress. And it worked in San Francisco. The San Francisco Medical Society backed us. It evolved. I became an alternate delegate to the AMA with Jess Bromley. And we got addiction medicine introduced into the AMA. There was also a time in which we started seeing the evolution of similar treatment programs across the state because the addiction problem was spreading, hitting youth all over the state of California. So we got a group together headed by Jess Bromley, administered by Gail Jara, of doctors all over the state of California, and we called it the California Society of Addiction Medicine.
It's just amazing because I doubt very many people even know where the name addiction medicine comes from, even know what the intent was. I mean, it was very subversive in a way. You call it addiction medicine, it's a subspecialty of medicine.
Right. That's what we wanted. We wanted to move it out of the criminal justice, it's a crime, into a subspecialty of medicines. And part of that was because in other areas, some doctors that volunteered at our clinic used the same detox techniques we use, and they got arrested. Now, these are more concerns. So it shouldn't be that you treat a disease one way in one part of the state and a completely different way in another part of the state. You had to have standards of practice that relate to diagnosis, treatment, aftercare planning. And so that started to growing the whole concept of addiction medicine with standards of practice, what is appropriate treatment.
Well, you led the movement toward treatment algorithms, and really at the Haight Ashbury, most everyone else in the United States would follow your detox protocols.
Right.
Then you even led the way in drug testing, and I think you have some special training in understanding drugs and drug testing.
Yeah, I was trained in clinical toxicology, which is study of diseases produced by drugs. Became very involved as addiction medicine integrated into the mainstream with the workplace initiatives. Very important because there was some major accidents and they said I know I was involved as the drug testing expert on the Exxon Valdez case.
Wow. I never even, what's the drug testing Exxon Valdez story?
Well, what happened there was Captain Hazelwood uh, was drunk. The head of Exxon Valdez crashed into Prince William Sound and dumped uh, a quarter of a load of oil into the waters, polluting it. And then they had, at that time, they had pilot drug testing. And they found out that he, was several times over the limit, and it was a huge lawsuit. And I was involved in the testing and analysis. Garrett O'Connor from the California Society of Medicine, he's the one that presented to the jury what alcoholism was. And I presented we could use drug testing to diagnose alcoholism and impairment. So there was a huge judgment against Exxon because Captain Hazelwood had been arrested for drunk driving, couldn't drive a car, but he could pilot the Exxon. And so there's huge, there's many different interpretations of this, but I don't want to get into too much detail because there might be lawyers listening to this.
It's supposed to be psychiatrists and doctors, but yeah, you're right. You did remind me of something with the way you framed addiction medicine and how you use language. I mean, I always say you saved more people with slogans than anyone, because sitting there in the Haight Ashbury, you're the one that said speed kills.
Speed kills, yeah, that was when the methamphetamine epidemic hit, and it was very destructive. And also to continue the narrative, Exxon after said anybody that ever attended an AA meeting and had a problem would be barred from employment. So that started the American Disabilities Act. Merrick Side of Addiction Medicine, Ian McDonald, other leaders, Garrett O'Connor, led the way to the American Disabilities Act. And this initiative said that addiction was the same as any other illness, and you could not discriminate against the individual for getting treatment. The fire them if they were impaired on the job, but not if they got treatment. And that started the whole workplace safety initiative of reentry. And that had huge impact. And of course, the slogan that had the biggest impact is I stood up to the health department in a moment of righteous indignation, said healthcare is a right, not a privilege. You cannot discriminate against a population by denying them health care. So healthcare is a right, not a privilege was a founding slogan of our clinic, but that has become the slogan for healthcare reform across the nation.
President Obama.
President Obama stated it, and it's also, we're in a very difficult time now, Mark, as you know, and you've written about, of which all of these core principles are being attacked. They're attacking Obamacare. They're attacking healthcare as a right, not a privilege. It's important to know the history of this, why it came about, but also move to the present and why this current political climate is so destructive to addiction medicine.
Well, you invented this model of care. I mean, basically, when I trained with Herb, we had the Yale program, which was principally medication delivery, was detox and medication management. But you, on the other side of the United States, said addiction should be treated as part of the whole person. We should treat their psychiatry. We should treat their medical problems. We shouldn't pass the buck. It should be all on us, and we should treat the whole person. I think you invented that, and that's really where the field's it seems to me where we're going, where we should go.
Integrated care or medication assisted treatment. But again, don't diminish your role, Mark. You and Herb developed some pharmacological techniques that we integrated into the clinic. And I think your audience needs to know that in that era, we had a broad network of people that communicated in addiction medicine. Yale, Haight Ashbury, strange interaction. But
Definitely.
we used your techniques at our clinic.
Well,
And medication.
you're always so kind. The best thing you ever did as far as me and Haight Ashbury was having me stay in your house,
Right.
you and Melissa, and basically, I remember speaking at Haight Ashbury fundraisers. Like
Right.
you had the annual fundraiser, and one time, I'll share this story. I think it's allowed to be shared. If not, you tell them and we'll cut it. But I remember it was the days of slideshows, and I remember bringing a carousel, and you had the meeting in a big hotel in a ballroom, and it was a luncheon, and I'm sitting up there, and you introduced me, and you said, "1 minute, do you mind if someone in the audience like says a few words before you talk?" And of course, I said, "Yeah, that's great." And then you brought up Robin Williams,
Right.
and so I had to follow Robin Williams.
He's a big supporter of our clinic that benefits for us. It was a very interesting interface between the medical clinic and the entertainment community in San Francisco.
Well, yeah, and I think also you. I don't know if this should be shared or could be shared, but I think we now, and I've spent a lot of time on this, and in the new opioid epidemic, and the importance of naloxone, Narcan, and I gave naloxone all over, since '74, but I think you gave it to Janis Joplin.
Yeah, we through rock medicine developed quite an association with the medical community, and we were called whenever there was a crisis uh, with that community. And she actually lived in Haight Ashbury at that time. This was in the '60s, and she did a big benefit from our clinic called Dr. Sunday's Medicine Show. Uh, Revered force in the Haight, and then she had overdosed on heroin. We got a call and we reversed her with Narcan. So we did Narcan early.
That's very early.
Yeah. And then I think what's happened is that it's been reformulated and a much easier. We used to give it by injection.
Oh, definitely. Now we have it intranasal.
Right. It's a lot better. There's been so much advances in the whole area. And one of the things that happened, a lot of these opiate antagonists were developed in the Department of Pharmacology at UCSF Med School. And I remember I was involved in an early study with them because you did not know at that time whether it had agonist effects. So that was the first time I actually met an addict in prison. And they were volunteers. And we gave them escalating doses of Narcan, brand name naltrexone, and to see if it had an agonist effect, and it didn't. There was a time in which we really didn't exactly know. This was before Suboxone, the mixed agonist, and for all the knowledge that's happened, it's just remarkable the advances of knowledge that we have and the tools that we have to treat addiction medicine that we just had begun during that era. And of course, you develop medication for an addiction, not a criminal. And that's where addiction medicine took off.
Well, I do know. I think you have a way about you that people want to facilitate your efforts to help other people. You're selfless, and I'm going back in my mind now that you reminded me about Robin Williams. I think I saw Vice President Harris at one of the functions. Right. I think she was a supporter when she was the city attorney.
Correct.
You introduced me to George Harrison.
Right.
I mean, I mean, everyone loves the Beatles, but who would really think that these people made it possible for you to treat. I don't know how many people did the Haight Ashbury Free Clinic treat. If you added them all up, would it be?
Added them all up, it was about 2 million. And as you know me, I'm big on pictures. So I got pictures of all those people on my board: George Harrison, Kamala Harris, uh, and Robin Williams. And it was a golden era at which, and it was also before, things. We had Bill Graham behind us at the Phil
Yeah,
Board. He's the one that set it up. So Kamala Harris was the DA. San Francisco was very progressive in this area, and she was a supporter. So it was an interesting era, different than now.
well, I mean, even without you, it doesn't happen. So you had the strange ability to understand the medicine, understand the testing, realize that we should develop protocols. People adopted Haight Ashbury detox protocols for, I don't know, I kind of think I'm remembering barbiturates, I'm remembering alcohol. What else, right? Like before there was an ASAM textbook, you guys had the standard practice.
Right. Yeah.
So
Yeah.
in a way, it was a clinic, but it had a very strong academic base with UC San Francisco.
Yes.
It had the community support, tremendous community support. You just said the Grateful Dead and other people paid for your patients to get treatment.
Correct.
That's hard to imagine anyone else pulling that off.
Well, I appreciate that, and you're correct. We had a strong academic base emanating from UCSF. We had some academicians on the clinic staff: Dr. Daryl Inaba, Dr. Don Wesson, Dr. John Newmeyer, uppers, downers, all arounders, this medicine, phenobarbital substitution withdrawal technique. So we had a very much of an integrated system. But as you know, Mark, the pivotal event in terms of getting government support was the Vietnam War, because we started seeing Vietnam vets come in, and they didn't like the way they were being treated at the VA. Think how different that is now when the VA has all these programs, but then they didn't. So they came to our clinic, and that's when we got our first federal grants. And of course, one of our mutual friends, Bob DuPont, developed an Institute of Drug Abuse then. I mean, this all came out of this explosive area. And then you got the career teachers program started, and now you got addiction medicine spread all over the United States and all spread all over the world. I had no idea any of this would happen.
Well, you were trying to make a difference one patient at a time, then one community at a time. And you had tremendous impact across the United States, especially with me. Let me cover a couple of other things. Being in San Francisco, you probably remember starting out thinking that cannabis was safe.
Right.
And even my own work early on, looking at Woodstock 1 cannabis, when it was 0.5% THC, there were experiments at Yale and other places where you could hardly tell the difference between someone who smoked cannabis, the old school cannabis, and someone that was holding their breath. I mean, that's hard for people today to recognize, but you've become a frontline information warrior in the current cannabis addiction crisis. Maybe you could talk about the evolution of that and some of your insights.
Well, you accurately described our belief system at that time. I got involved with cannabis because so many people that came there had involved with cannabis. We did a study the people that came to the Haight Ashbury Clinic, 97% had used marijuana, and we thought maybe 3% didn't understand the question. Remember, this was totally unknown at that time that a large group of middle-class kids would be smoking marijuana. So it was the new social drug. We also, I was deeply involved in social justice because what was happening is if you were black or you had a 17 higher chance of getting a felony if arrested for possession, because then you could get arrested for possession. So that was my take. We did a lot of early studies on adverse effects of marijuana because we saw them at the clinic. But as you pointed out, the marijuana then was so much less potent. And what's been troubling, I serve as a medical consultant to a program called Mirrorwood for adolescents, and we're seeing it at rock concerts now. The marijuana now is not, say, it's not your mother's marijuana. The industries taken over have distilled higher concentrations of THC and driven out the cannabidiol. It's sometimes these vapes are 70, 60, 50%. It's very different. And you're starting to see a whole series of cannabis hyperemesis, cannabis psychosis. At Muirwood, we see these kids come in dependent on cannabis and having actual physical withdrawal.
Sure.
Signs and symptoms of physical withdrawal. Now, it doesn't mean everybody that touches it has that, just like everybody that touches alcohol doesn't become an alcoholic, but 10 to 15% of the population that's had an adverse effect with cannabis goes on to have a cannabis use disorder.
Yeah, so we did studies on, with my colleagues at the Brain Institute, developed a smoking rat model for cannabis. And you could produce cannabis withdrawal by giving a cannabinoid antagonist to someone who's just in the environment of a cannabis smoker. Like it in a highly potent form, it's clearly addicting. And I think in psychiatry, they're now saying maybe 2 to 3 times the number of cases of schizophrenia will result from the widespread access to highly potent cannabis smoking among teens. And I know Nora has tried to get the word out, and other experts, that it's like you said, it's a different substance, that it's associated with addiction risks, it's associated with school failure. But I don't think people take seriously the idea that it was bad enough that we had anyone in the United States with schizophrenia, let alone doubling or tripling that.
Correct. Yeah, I saw that study, and that was very alarming. And I think we're learning more about the adolescent brain and what happens when you introduce toxins to it. And so you start out studying one area, and then it leads into another area. And the cannabis that we're seeing now is much more potent and much more dangerous. I am still not I'm still education, prevention, treatment. I don't think you should get arrested, but I think the public needs to know how dangerous it is, and particularly the treatment programs. As you know, we got 12-step program started at our clinic. That was the transformation. And my wife, Millicent, who's been in recovery now for 48 years, started the first Narcotics Anonymous meeting. And when somebody came into a 12-step group and say, I'm dependent on cannabis, people laughed. And now they're taking it seriously, happening throughout society.
Well, we should congratulate her on that. How many years? You said 48?
48, yeah.
Well, that's just incredible. And I do think also people might be surprised that such a pioneer as yourself in the field is also a real supporter of 12-step and AA and NA programs.
Yes. Yeah, I'm very much of a supporter because I've found that individuals that embrace 12-step are the ones that do the best. And then there's a big push to get the mainstream of medicine to understand the principles of 12-step. And I know that you've done it. It's one of your best articles. I really like that article on California Sober, because that's a big
Thank you so much.
big focus on clean and sober. There's a group that hangs on to marijuana, and 12-step recovery does not do as well.
Well, your whole family has been a role model in so many ways early on in the treating addiction as a disease, and now taking recovery seriously. It's not a question of why haven't you been cured yet. It's going to meetings and doing the work.
Yeah, but the lifetime prevalence of a chronic disease that you continue to need to work on your recovery. And then if you embrace 12 steps, you find out it's a good program for living. It helps you deal with all the issues that life brings up, particularly as you age or when you're young. And so I think that your articles on 12-step recovery, which are widely read, are some of the strongest things that you've done. You've done a lot of good stuff, but having somebody with your prestige embrace 12-step recovery helps the mainstream of medicine understand it, which is crucial.
Well, first of all, I appreciate that. At Yale, that wasn't a big thing. We did, when I was in Florida, I was lucky enough to serve on the PRN committee with Roger Getz and do 20 years helping recovering doctors retain their license and practice. And when Bob DuPont asked me to look at some data, the data on the 5-year outcomes of physicians with all sorts of addictions, whether opioid or alcohol, the data is like 80 or more percent are fully back at work. Their wives are happy with them. Their jobs happy with them. And they're clean and sober. So like you can't refute the data. One thing, and I think you have the same in California, like the Florida PRN.
Yeah, we were very early in that. And of course, Florida made huge progress with you and Scott Teitelbaum. But we've had a backlash here in California, backlash against the physician recovery programs, equating addiction with a bad doctor. So it's one of the things I lament, that we seem to be going backward in certain areas. And I hope we can reverse it. By the way, one of the things that helps our initiative are those studies that you did. For example, I recall one of the key variables that Bob talked about in that article with you was drug testing and participation, And
if you think about randomized testing, right? People are against it on a philosophical basis. But if you think about it in terms of behavior change, it's a cognitive behavioral treatment all by itself. Every day you're randomized to test or no test every single day. So in your mind, like you keep real the fact that it's one day at a time. You're right. One. How could that be bad? I don't like the idea of sacrificing people to the altar of some notion of free will when they decide themselves that. I mean, a funny thing we learned about this. We have 5-year contracts in Florida. Lisa Merlo asked the doctors after 5 years what their intention was. Their intention is to sign up for another 5 years of monitoring.
Uh-huh.
Yeah, they don't. I mean, they're they're working to prevent their relapse every day.
Right.
And they like the way their life's going. To someone to say, no, you're a bad role model I don't get that at all. Right now, we don't have any cures. We may find a cure sometime, but we have treatment. And we have treatment that works. And California led the way in this 12-step treatment. You can't overestimate the importance of a sponsor Caduceus peer group, drug testing, staying engaged rather than isolated.
Yeah, one of the articles that you did, and I don't want to take words out of your mouth, but you broke down the principles like one day at a time.
Yeah.
Solid clinical principle, uh, taking slogans and then showing the sound medical principles behind it. I use that for my patients now.
Well, I tell you, I had a blast doing that because I'm thinking of all the things I've learned, and I couldn't tell what to title this, but let's discuss one of them that I put in there, which was that you can't change a pickle back into a cucumber.
Yeah, I use that one a lot. That's
so the notion for everybody here is that you have cucumbers and then you have all these drug exposure, and at some point the cucumber becomes a pickle, but good luck trying to get it back.
right. And that's a huge issue here in San Francisco politically. San Francisco, because of all the overdoses and all the destruction addiction has done, particularly downtown, has moved into harm reduction. And I support harm reduction to reduce overdoses, but it should be viewed as a spectrum. And recovery should be the ultimate end. And so many people, they don't accept that principle. They reduce the harm, they continue to use, and then they go back. So it's a big debate here in San Francisco. And the recent mayor, Daniel Lurie, and Dorsey on the Board of Supervisors has pushed more to integrate recovery into San Francisco.
Well, that would be great because you think about it. One of my mentees who did one of these gold standard interviews, Brian Furlan, his main contribution from a research point of view was to show that at the time of an overdose is the ideal time, is a teachable moment, and you can get people into treatment. But you shouldn't say to yourself, well, the only thing this person needs is more naloxone. That's going to put them in a continuous loop of slips, relapses, overdose, slips, relapse, overdoses until it's over for them. On the other hand, we've shown for doctors and others that treatment works. But,
right.
Florida's on the other side in that we even have involuntary commitment. So when someone is really, they've lost free will, they've lost absolute control, we can commit them and then bring them to a judge to describe the case, and they can get mandated to treatment. The relevant thing of this is Bob DuPont showed this just as well with Lisa, was outcomes in mandated treatment for physicians or coerced treatment are the same as just showing up and saying, I want treatment.
Right. Yeah, that evidence is very strong. Mm-hmm. The issue relative to the street population, we have in San Francisco what's called frequent flyers, because we've had fentanyl, but we've had the big increase in methamphetamine. They go into the ER 5, 6, 7 times and use up a lot of the resources. And so we've, through the Medical Society, have advanced the idea of involuntary commitment to treatment.
Sure.
We've got a tremendous backlash against it. So that's where we look at other states and look at the data and see what works.
Yeah, I mean, it even Nora one time wrote an article about addiction being the loss of free will. Now,
exactly.
And it became highly politicized, and it was quite unfortunate because you start off with the definition, your old definition of addiction, it's loss of control. But loss of control to the nth power is lack of free will.
Right. That is a principle that is very important in understanding the addictive process. You use initially because you're curious, and you use because you like it. And in a certain population, whether alcohol or any other drug, they start becoming dependent. And then there's a certain subset that moves into the addictive process and loses control. And no matter when they get exposed, they move into a relapse, and they relapse faster and harder than did the last time. That's where the neuroscience has been so strong. People just don't understand that. They think that addiction is a thought process. I'm going to go out and start out one's too many, a thousand's not enough, use, and have all sorts of negative consequences. That's not the way the brain works.
No, I agree. Well, in the as we're getting closer to the end of this, I did want to remember the Ken Kesey and the other uh, San Francisco pioneers, because we're circling back to psychedelics.
Right.
I asked you to write a paper for a journal I edited
Right.
on
Thank you.
psychedelic. No. You were there day one. So it would be interesting to share, if you could share your insights about psychedelics way back when, psychedelics now, and what you think going forward.
Well, as you know, my early career, I was very involved in psychedelic drug research. I was a local drug expert. We set up a top-down center. Large numbers of young people used psychedelics, particularly LSD. It was the gravitas for the whole counterculture movement and the dance and the music and Grateful Dead, and a whole art form came out of it. So it was absolutely fascinating. But we were the ones that said, well, that's great, but there's a certain number of people that have really adverse reactions, and some have psychotic reactions. And it was too wide open then. I remember walking back from the Human Being, and Ken Kesey I just looked in this area, and there was a big room there. And Ken Kesey had, can you pass the acid test? And they'd put LSD and Kool-Aid. And there's a guy back in the back that was in one of those tanks having a death rebirth experience. And I'm just walking home. What's going on here? And so you saw the evolution of the counterculture and the psychedelic drugs. I don't want to romanticize it, but then it was criminalized. And the aspect of the criminalization, it really didn't do much for the drug culture, because that drug culture had moved on to speed and heroin, but it had a devastating effect on psychedelic drug research, particularly at major institutions like UCSF and Johns Hopkins. But then there's been this rebirth of research, and a fascinating rebirth of understanding of how psychedelics act in the brain. The classical psychedelics, as you know, are 5-HT2A receptor agonists that open up that primitive area of the brain. Fascinating stuff on PTSD, fascinating studies on, alcoholism and other types of things. And there was just a study out of UCSF. It was a pilot study, and of course, scientifically, it has to be replicated on the use of psilocybin for Parkinsonism.
Sure, I saw that.
Yeah, that's amazing.
Mind-boggling.
Mind-boggling. So I think that they have some biological aspects of it to help heal atrophied dendrites, and psychological aspects. They don't know, but with the advance of brain science and neuroimaging and all the things, there's a new psychedelic revolution. But they've started a group here in San Francisco, started by mothers whose kids died after a psychedelic experience. One woman had her niece had a name was Beth Parker, and the niece took psilocybin in a isolated area, had a serious depression, and jumped off the Golden Gate Bridge. So, like anything, there's the good and the bad, and I hope that the psychedelics will take the path valuable therapeutics, which I think is the most important, and then guidelines. They have uh, this kind of network about if you want a trip, what are the guidelines for it? So it's really interesting how this has moved from therapeutic to the culture, and that if you want a trip, in a certain sense, harm reduction. Don't do it alone. Don't do it this. But whether these young people will adhere to this is a different issue.
Did you ever meet Hoffman?
Oh yeah, got a picture of him on my wall right here.
I thought I remembered that.
Albert Hoffman.
So, did you go to Switzerland or did he come visit you?
No, I went on a pilgrimage to Switzerland, and he had read our Journal of Psychedelic Drugs, and he talked about the early history of psychedelics, and he was shocked. He had that book, LSD, My Problem Child, and nobody thought it was developed by Sandoz. It was a therapy agent. Nobody thought that it would become a recreational drug taken in these uncontrolled circumstances. So we want to get back to when things were more balanced. And I think education, information, trying to figure out the way to do it.
There's a wonder drug aspect to it, but Timothy Leary gave us a 30-year detour.
Right. That's an accurate statement. Turn on, tune in, drop out. It was interesting.
Definitely.
Yeah, it's interesting. We're talking about the old days. He stayed at my house one night, Timothy.
Yeah, I'm sure he did.
And then we had dinner, and we auctioned off his toothbrush for our clinic. I think people thought maybe there was some particles of LSD on it, but he left his toothbrush there. We had this thing, Timothy Leary's toothbrush, because he was a very, very popular, but he really produced a nice guy, a far out guy, but he really detoured the whole thing.
Yeah. Well, it's just like you said, it's the difference between the use of a medicine that's been evaluated and tested. And I think the best modern example we have is with these problems is ketamine. So here you have someone comes up with ketamine reduces depression. Ketamine is more effective in treatment-resistant depression than other treatments, and Johnson & Johnson invents an intranasal form of it so that it won't be diverted and it won't be abused. And both of those are true. That, however, didn't stop people from saying, well, if you could sell ketamine for depression, then maybe I should take ketamine for depression on my own. And that's been a problem.
Yeah, you've written about this. We're in our treatment programs, and I'm more involved in Marin County now.
Altamira and stuff. They have for people who have ketamine use disorder. It didn't even exist in the DSM.
Right, ketamine use disorders coming in, and I interview them at Altamira, and I say, well, how did it start? Well, I took ketamine in a therapeutic context for depression. And then I kept on. And then where'd you get it from? Well, I started buying it in the street. You go down to the Tenderloin and buy ketamine, a middle-class woman going to the Tenderloin, the middle of the hard drug culture. So it is a lesson in community education, how we retain the good, the positive, and minimize the negative, and figure out what the proper community response is.
So before we go, I of course have to thank you for your life of great service to others, your life as a role model for what an addiction medicine physician might mean and could be, and just your generosity of spirit and academic rigor in the face of all kinds of life's challenges. You're just the best.
Thank you very much, Mark. And back at you. You know, look forward to reading your next column.
Thanks. I got one coming out of virtual reality raves.
Oh, I love it.
That's what should be out today. Thanks a lot.
Okay, thank you very much, Mark.